tertiary prevention can be applicable to antipsychotics as well. I've not seen any literature to suggest that ever. Maybe someone has thought of it. I've been thinking about that for some time, and I think if we can, for example, kind of advocate that topic in an article or something, I would think it would be relevant, because psychiatrists, they will think twice before starting medication, increasing doses, and so on and so forth. Yeah, absolutely.
Thank you, Dr. Aisha, for this interesting talk. It started lots of discussions. I will start with a comment and then end with a question. The comment is that I believe in this. I have been trying this for many years. Unfortunately, I did not succeed in stopping any treatment from any patient. Patients will come in 9 months, 1 year. But what's interesting and what you showed us is that maybe we need to hang on. When I see the patients in 10 months, give them another try, maybe give them benzodiazepine and wait, because the 6 years or the 7 years results were surprising. I was trying to find a way to help patients stop. I don't motivate patients to stop. Patients come wanting to stop and going with empowerment, taking what they want. We do it gradually with psychoeducation to patients and family, preparing them for relapse and taking preventable measures to prevent that. But still we ended with relapse. But maybe taking from this presentation, maybe I need to hang on more and ask them not to go to private and restart medications. In most cases, it is they relapse all of a sudden, they go to private, treatment is restarted. I believe we need to do this not to give up on our patients, because more is not always good with medications. I have treated patients who have some psychotic features without medication, so we don't need to use antipsychotics with lots of side effects with all patients. That was the comment. The question is lorazepam. Lorazepam is a promising antipsychotic with a very good metabolic profile. I mean, it is being said that it's as good as olanzapine, but does not cause as much of metabolic syndrome like Abilify. It's been in the market, as far as I know, from 2013. Any updates on this? Did you read about it? Any updates from our administration if we'll include it?
Update about what? Availability of it? It will be available soon. We already sent it for approval, and I was in charge for sending the monograph for this, and I think it will be soon available in our hospital. And by the way, Latuda is very similar to quetiapine without those side effects, so you can use it for bipolar depression, for schizophrenia, and it's a good medication, and as shown in the studies. But we will know when we use it. Its name is lorazepam. Yes. Yeah. So it will be. We already sent the request in July, and they asked for class review for the all antipsychotics. I prepared it. We sent it, and we hope that we'll have it shortly. So it's almost the same like quetiapine, but without the prolactin problem and without the weight problem as well, and sedation as well. Regarding my comment for all our colleagues said all possible things that can be said, but I'm afraid that most of our talk is talking about our own decisions. We need to have shared decisions with our patients. So what I'm doing usually is that from the start I'm trying to involve my patients and the family and the decision for the care plan for what are we going to do to give for them, and I'm trying to reduce the medication as much as I can, and this will be I'm not going to reduce it in 4 weeks time. Maybe it will take more than 3 to 4 months in each dose lowering. I succeed to have many patients on very low doses of antipsychotics. They are better on performance, and our aim in psychiatric rehabilitation is the functional recovery. Yes. So we are more interested in quality of life of patients. So it's better to have your patients with some few symptoms, but better functioning than having no symptoms and he's not functioning. So shared decision is very important. We need to have those in our mind when we are discussing with our patients. Thank you.
Thank you, Dr. Aisha. I don't think I will add much to what have been said, but it came to me as a surprise, to be honest, that the people, when they studied first episode psychosis after recovery at 7 years period, and it seemed like discontinuation or even very little amount of medication